So good afternoon, everyone. Welcome to the fifth edition of the postgraduate teaching program, which is held on a weekly basis every Friday, 3 to 4 p.m. of Academy of Pediatrics, Uttar Pradesh. And on this week, we have a very, very accomplished speaker and a PG teacher from Maharashtra, Mumbai, Dr. Mahesh Mohitasar. And we are very thankful that despite his all busy schedule and engagements, he has agreed to be part of this PG session, and I think the PGs will thoroughly enjoy his approach of questioning and taking up the case, which we have already seen in the DIAP platform. I think he had around hosted 200 PG online sessions when this whole business of online education started, and he anchored those so many sessions. I think his name can go in some Linka book of records, and how he used to question the presenters. It was really a treat to watch and more interesting than the sessions itself. So thank you, Dr. Mahesh sir. Thank you, Dr. Ajay Kalra sir. Our most respected figure and stalwart from Academy of Pediatrics Uttar Pradesh, the pillar of AOP UP. And thank you for agreeing to be the chairperson. And thank you, Dr. Anurag Katiyar, and from Lucknow. He is also a very young and upcoming figure and a future of AOP UP. And thank you for agreeing to be the chairperson. And before we proceed to the session, I request Dr. Alka Agrawal, madam, the president of the Academy of Pediatrics Uttar Pradesh, to please stand at welcome note. Thank you, ma'am.
Thank you very much, sir. On behalf of Academy of Pediatrics UP, I welcome you all the postgraduates and the stalwarts who have joined. Special welcome to Dr. Vineet. He has taken out his time from such a busy schedule. वो उत्तर प्रदेश भी देखते हैं, पूरी कंट्री भी देखते हैं, उसके बाद फिर अगर पीजी सेशंस में भी इंटरेस्टेडली अगर ज्वाइन करते हैं तो it just goes out to say that how interesting these sessions can be. So thank you very much, sir, for joining. Thank you, Dr. Mahesh Mohite, for taking out your time. We have heard you in several modules, CIAP modules, especially the track module, I remember, and infectious disease module he was a part of. So welcome, sir, to AOP once again. And welcome, Dr. Ajay Kalra, sir. Welcome, Dr. Anurag Katiyar. Both the chairpersons, are very balanced, because one is very rich in experience and the other one is young and youthful, with the bubbling with knowledge. So we have a very balanced team of chairpersons today. Welcome, Dr. Shirish, Dr. Sethi, for honoring us and with your presence today. So I think with these words, I would want to hand over to Dr. Shalabh to carry on the proceedings. Thank you, sir.
Before we start with the presentation, I want to tell you that we have to be a very interactive session. Though ideally it would have been presented, the case will be presented by the postgraduates, but I think Dr. Mahesh Mohitasar has expressed his desire, and rightly so, that it should be interactive. And I request all the postgraduates to please interact freely, write in the chat box, and even you can unmute and ask questions and answer those queries which have been raised by Dr. Mahesh Mohitasar. And before we proceed, I request Honorary Secretary General, a very own from UP, Dr. Vineet Saxena, to please give his remarks. And also, it's take this honor of introducing Dr. Ajay Kalra sir also after this address.
Thank you, Shalabh. So I am here to say my greetings, my well wishes to my dear Mahesh Mohite. Mahesh has been very dear to all of us. Me, Vivek Saxena, Pyali, and Shalabh had a very good time in 2018 with the EB. Yes. Contribution of Mahesh to IAP is tremendous, amazing. The way he conceived and carry forward DIAP. So मैं तो log end में करता था, because in the end पूरे talk का निचोड़ महेश सबको सुना देता था. So the tremendous capabilities, and I am happy that he's here. I know how much he is busy. For IAP, I had many assignments for him in my mind, but as he's a chairperson of intensive care chapter, and he has so many plans. So, those शुरुआत की, he started this nursing teaching classes. So I just today only I saw a viewership. It is seen not only in India but also in Bangladesh, Sri Lanka, and neighboring country. So he is many ideas for this taking forward intensive care chapter in IAP, but Mahesh, we will not leave you next year. Next year, you have to play
I will be there. I'll be there.
IPA as well as Indian Academy of Pediatrics. For this, we can spare you for your chapter, but still IAP need you. All the best for all your future, and we are proud of Mahesh that we have such type of member. Now over
Thank
to
you.
Shalabh.
Thank you very much, sir.
Vinit, can you introduce Dr. Kalra, sir? You will know none better than you to introduce Dr. Kalra, sir.
I don't think it is needed. Vinit, चलो skip करते हैं. Let's start with Mohit. My
Dr. Ajay
introduction.
Kalra, sir, well, truly is saying that is a humble person. He's beyond all those things that needs to be introduced. He's a pillar of AOP UP, and the AOP UP, which is in the present shape, is a lot of because of Dr. Ajay Kalra, sir. Despite apart from all his academic accomplishments, which I don't think needed to elaborate, I just want to tell the new generation that we very difficult to find a man of such principles and integrity as Dr. Ajay Kalra, sir. And our next chairperson, Dr. Anurag Katiyar. He's a young and dynamic member from AOP Lucknow, and is a pediatrician and has a special interest in developmental neurology at Lucknow, and president-elect of the Lucknow IAP and the national tailor of NRP and BLS program, faculty in various IAP action plans like cradle to crayons, basics of behavior, clinical foods, etc. And is has a special passion for running as an ultra marathon runner. So now I request the chairpersons to please take over the session, and I request Dr. Anurag Katiyar to please extend the introduction of Dr. Mahesh. And before that, Dr. Ajay is there. Can you please, Dr. Ajay Srivastava? Dr. Ajay.
Hello, sir.
Just a few words from our secretary, AOP UP, Dr. Ajay.
Thank you, Dr. Shalabh, sir. When you are here, I think our UPPG activity is already, it's rocking, and within 1.5 months, we are going to have our 5th activity, and all the best. Let us continue like this. And I welcome Dr. Mahesh Mohite. Sir, we were co-EV members in 2020,
yes.
and I think उस वक्त तक अगर कुछ लोग कम भी जानते हो इन्हें, तो ऑल ओवर इंडिया इन्होंने DIAP के एक होता नहीं फेस ऑफ DIAP, बकुल भाई एक तरफ और महेश मोहिते हार, सारे के सारे, I think initial 6 to 7 months almost all scientific deliberations he was used to carry out. And welcome, sir, for our UPIP platform.
Thank you.
And I hope we will have a long association. And thank you, Dr. Shalabh. Over to you, please.
Yes, Dr. Anurag.
Thank you, Dr. Shalabh, sir, for giving me this opportunity. I would welcome today's speaker, Dr. Mahesh Mohitasar. He is a pediatric and neonatal intensivist at Sai Child Care Clinic, New Panvel, and also at DJ Wadia Children's Hospital, Mumbai. He is president-elect 2022 at IAP Intensive Care Chapter, and is a renowned teacher and council member of Pediatric Critical Care India. And I request him to deliver his talk on today's topic on interpretation and approach of edema and delayed development and difficulty in walking in children. Mohite, sir.
Yes, sir. Yes, sir.
Sir, please unmute, sir. Mohite, sir, please unmute.
Good afternoon, all. AOP UP, first of all, thank you very much for inviting me for such a prestigious session. PG teaching has been very dear and near to us. Dr. Ajay Kalra, sir, Professor Ajay Kalra, sir, is there. In fact, sir, I have heard your talk so many times in national conferences. So I am having this great opportunity of speaking in front of you. So if I make some mistakes, please pull our ears. You have all the rights to do that. not to forget
Well,
my dear friend.
I am being a learner today. I'll be learning from you. Thank you.
That's your humbleness, sir. That's
Thank
how it's my teacher, Dr. Ambedkar, used to always say that. And my friend, Dr. Shalabh Kumar, Dr. Shirish Bhatnagar. Dr. Bhatnagar, I've heard you many times in your GI sessions. Dr. Anurag Katiyar, and my dear friend, Dr. Vinit Saxena. He always speaks so much that I always feel sort of pampered. He's a person, I mean, Marathi we call, say something called as Ajata Shatru. Ajata Shatru is a person don't have any enemy at all, and this is one kind of a person who, I mean, you just can't be enemy to him. He's just so dear and so nice person. Thank you very much for inviting me. I'll quickly go on to the session. I'm supposed to conduct a postgraduate clinic rather than giving a talk. So what I would suggest, those postgraduate students are there, they all unmute your videos. What we are going to do is something on a prototype of, we have been conducting postgraduate clinics in Mumbai with under my teacher, Dr. Ambedkar sir's team. We are about 5 or 6, and almost 20 years we have been conducting. Every Thursday evening is a session. So I'll take the case on the same lines, wherein I will present the case as only history, then we'll discuss the analysis of the history, then I'll give you the clinical findings. On that, we'll discuss the analysis, then we'll go for investigations, and as the case evolves, everybody can give their inputs into that. So I request the postgraduates which are on the Zoom platform, please unmute themselves, and then I will start sharing my slides. And they can unmute videos. They can unmute their videos and they can directly interact with me. It will be a real fun. You start interacting, that's a real fun. So great, I'm seeing few postgraduates, the students. Yes, I'm very happy. So I'm sure they're all prepared to take it. I've given the glimpse of the case, though the case will evolve into something more complexity. I've chosen a kind of case which will be more of multisystem. So I'll start sharing my slides. So are my slides visible? And am I audible?
Yes, sir.
Great. My slides are also visible, right?
Yes, sir.
Yes, sir.
So here is the case. I'll give the history briefs and then we'll discuss on the history. If you want to note down the points, please do that. Fine. So this was X, 4.5 years old boy, 3rd degree consanguinity, whose birth weight was 2.8 kg. He was brought with complaints of Anasaka since last 15 days, delayed development, chronic skin disorder since early infancy, and irritability. I'll give the details of it. This Anasaka actually started 15 days ago. More swelling in the morning, though it was always there in the evening as well. There's no decreased urine noticed by the parents. No red or black color urine, no dyspnea, no jaundice, no such edema episodes in the past. Child remains irritable most of the times since many days. They don't know exactly when it started. Since the disease is of a prolonged duration, they don't know exact details of it, but they said bahut din se wo irritable rehta hai. Something about the delayed development, which is the second important complaint. Gross motors at 4.5 years, this child is sitting. He started sitting at 1 year. He started standing at 2 years, walking at 2.5 years. He walked for next 1 year. He stopped walking since last 1 year. Only he sits now. He moves hands voluntarily, but not moving legs and cannot stand. His fine motor, the detailed stages they don't remember, but he feeds himself properly. Now he can hold pen, scribble, draw few figures, clothing helped by the mother. Speech and cognitive, he has got delayed start of the speech around 18 months. Now he can speak sentences with meanings, he responds appropriately, he can converse it, and he's dry by day. That's about his cognition. He has some skin rashes. He was all right till 3 months of age. Parents showed me the photographs which are looking like any normal infant. Then he started, the rashes started all over the body. The rashes presently are, according to description, they are reddish and they are pruritic with a skin peeling, but no ulcerations. He was diagnosed somewhere outside. He has already, as you can understand, the disease of 4.5 years, almost 4 years. He has come with a big bunch of files. So was diagnosed by a dermatologist as infantile psoriasis and was being treated. His prescription showed multiple steroid ointments and systemic steroids prescribed in last 2 to 3 years, but no steroids in last 1 year. There is no history suggestive of pustules or scars in those lesions. He has received multiple, the treatment history is received multiple treatment. Once he was hospitalized at 6 months of age for whatever jaundice as a prescription, but nothing detailed. So he was admitted for about 8 days. Otherwise, no admission so far, and a lot of OPD basis treatment, but nothing in conclusion. It was a full-term normal delivery, cried immediately, no significant antenatal or perinatal postnatal history at that time. No history suggestive of altered sensorium or seizure, no facial movements difficulty, no localized weakness. He reports pain in the trunk and the limbs, no recurrent ear infection, no recurrent diarrhea, and no other systemic recurrent infections in the past. He is from upper middle class. His diet is grossly restricted at this point of time, though initially was exclusively breastfed till almost 6 months, and then he was taking diet well till almost 3 years. But last about 2-3 months, it has dropped down, and this is his present diet, which is showing deficit of calorie of 4 to 500. He gets about 500 kilocalorie. We calculated that, and protein just about 10 grams a day. So let's stop here, and I want the postgraduates to take this history. I may stop sharing the screen and I will come back again later on. So the postgraduates, I want to unmute your cameras and interact. How will you take? So can you raise? Dr. Gunjan is there, Dr. Shubhika is there, Dr. Read me. Can you change your name so that I can call you by name? Then Dr. Mrudula Jain is there. Yeah, some read me note. Can you change the name, please? I'm sure you are a postgraduate. Great. So I'm seeing at least 5-6 good enthusiastic postgraduates, and I'm sure together we'll crack this case. So Dr. Gunjan, how will you take this case? He's at 4.5-year-old child with 15 days Anasaka. Can you take that 15 days Anasaka? How do you look at this complaint?
Sir, Anasaka, which is generalized, maybe because of, as you told in history, that he is not taking proteins appropriately. Hypoproteinemia is there. So it
Very
may
good.
be a cause.
What are the other causes of Anasaka?
Sir, you also suggested that he was on steroids.
Okay.
So that.
So, Dr. Shubhika, do you agree with him that steroid give rise to Anasaka?
Yes, sir. Other causes could be, sir.
Before that, she said steroid causes Anasaka. Is that right statement? Okay. So steroid will give rise to localized puffiness of face, hirsutism, not Anasarca per se. When I say Anasarca, it's an extra water in the third phase, probably in the interstitial, right?
I noticed steroid because some of the nephrotic syndrome children, they take steroids on a course.
Agreed.
So that was my point to discuss regarding steroid.
Perfect. So basically, Anasarca is not caused by steroid.
Yes,
but
sir.
Steroid can give rise to some puffiness like presentation.
Yes,
so
sir.
What are the other causes of Anasarca, Dr. Shubhika?
So constrictive, it could be due to cardiac condition, pericarditis, heart failure. It could be due to nephrotic syndrome, and other causes could be, sir, it could be seen in severe late stages of Budd-Chiari malformation. So
I will put it the other way. Can you tell me the pathogenesis of edema or Anasarca? If I have to take, because once you get a pathogenesis, then you know the multiple headings under which you can put 10 names of the condition, and suddenly land up getting 50 causes, right? So Anasarca or an edema, how do you look? What are the pathogenesis of edema or Anasarca?
Sir, it mostly occurs due to decrease in either oncotic pressure.
Excellent.
That is,
Very good.
is less in the body, or
Very
sir,
good.
it occurs due to increase in capillary hydrostatic pressure.
Excellent. Very good. Anything else? Example of capillary hydrostatic pressure?
At arterial and
Increased capillary hydrostatic pressure. Very good.
Sir, vasculitis.
I will stay there. Somebody, Dr. Vidisha, what is the cause of increased hydrostatic pressure? Maybe edema. An example.
Increase oncotic pressure.
It's basically oncotic pressure. So that's one cause. Second is increased hydrostatic pressure. So what is the cause of that? It's a venous hydrostatic pressure, and that's because of increased cardiac pressures. So cardiac failure, typical cardiac failure is the increased congestive cardiac failure or any obstruction on the venous side. So you said just now Budd-Chiari or IVC obstruction. Fine. So they will give us an increase of oncotic pressure or increased hydrostatic pressure. Okay. And then that can be localized or generalized. We'll come to that later. Any other pathology which will give rise to any other pathogenesis which will give rise to edema?
so
you
venous
say very good.
Allergic diseases and angioneurotic edema.
I'm sorry. So what is the pathology there? It's a capillary leak.
Capillary increase permeability.
So that can be immunological, that can be infective, that can be inflammatory. Capillary leak, like typical in dengue shock.
Yes, sir.
Okay, we get capillary leak. Or as you said, localized edema, as in case of angioneurosis or kind of allergic condition. One more condition, one more pathophysiology which will give rise to edema. Lymphatic obstructions. Fine. I mean, just try to recall the whole thing. Blood will come from the arterial side, will go to arterial capillaries. From that, it will be percolated into tissue and taken back by the venous system. Now, where all can be the problem? When the venous system block, it will leak outside. Normally, also little bit of blood is leaking into the system and remain, and that's what little bit is taken care by the lymphatics. Okay. Now you can have pathologies at multiple end: venous obstruction, which is increased hydrostatic pressure, or lymphatic block, which will cause local edema, or the vessels are leaky, so they'll leak the water. And last, if there is decreased osmotic pressure. So take it systematically, you will not forget. Now under these headings, you can easily put 5, 10 causes. You suddenly have 20, 30, 40 causes. Okay. Now, what else? So this is one. What is the cause of edema? So you said cardiac failure. It's can a hepatic condition give rise to edema? Can a hepatic failure give rise to edema? How? Dr. Gunjan, can you tell us how to? Yeah.
Yes, sir. Protein loss can lead to hypoalbuminemia is seen with many hepatic diseases, many hepatic conditions. So it can.
So rather than protein loss, it's a decreased production of albumin by the failing liver, right? It will happen quite late. It won't happen in the early phase. Maybe by 60-70% liver function is damaged. Then you will have the hypoalbuminemia coming up. Now, from this history, what kind of anasarca this is likely to be? What can be the likely cause of this anasarca? 15 days edema progressive. Now, is this cardiac anasarca? Can it is the cardiac anasarca? Dr. Irfan?
No.
Ifa Khan. Dr. Ifa Khan.
Sir, because there is no history of any respiratory distress is not there.
Very good. So far before, like 15 days, she is edematous and there is no respiratory distress. But can it still happen? I was told that right-sided failure will give rise to edema, left-sided will give rise to respiratory distress. So can this be right-sided failure and anasarca?
Sir, but before that, I think respiratory distress, some form of respiratory distress will come.
See, in adult, you can have a univentricular failure generally, but in pediatric, usually it's very, very rare. You almost always have biventricular failure. So by the time one ventricle shows off clearly, the other ventricle has to fail. Secondly, cardiac failure presenting as edema anasarca is not very common in pediatric age group. They will present invariably with respiratory distress as a manifestation of LVF, and later on he may develop little bit of edema or weight gain. So fine, this is not cardiac. Can this be hepatic edema?
It could be, but it could be, sir. It could be a hepatic edema. But there is no icterus.
But sir, there is no jaundice.
Very good.
Jaundice.
No jaundice is there.
Fine.
So, but anictric cause, it may be possible.
Fine.
Patient may be in chronic liver disease, and then.
Okay. So it can be fine, but as you said, generally some hepatic disease manifestations like jaundice, dark color urine, some nausea of all many days, some kind of prodromes which may be seen in a chronic disease and severely sick child. Of course, we haven't gone through the anthropometry and subsequently, but we'll keep that as a possibility. But this child don't have a definite hepatic manifestation. Can this be quasi-occur? Decrease albumin. You said decrease osmotic pressure. Can this be quasi-occur?
It could be. Yes, sir, it could be. But we have to see the anthropometry.
Perfect. We'll go to that. Can this be dengue shock syndrome? Anasaka. Sorry. Can this be dengue shock syndrome? We said Anasaka is there in dengue as well. So can this be dengue shock syndrome?
But yes. Sir, but edema is for 15 days.
Excellent. And dengue shock, when it becomes edematic, he is extremely sick child. He won't be seen with rest of the irritability and all those as presentation. They are sick. Or before they become edematous, they are really sick. They are straight venous. This kind of a child with so much of edema would have been in ICU. So a lot of things. But what you said is absolutely important. Persisting for 15 days, dengue shock is out. Perfect. Excellent. So what is the likely cause in this child of the edema, Anasarka?
It could be nutritional, sir.
Great. Excellent. So when the nutritional thing comes, we'll move on to that, the next point. So let's note that edema could be nutritional. You mean to say it's a hypoproteinemia? Do I go with that? Perfect. So let's go to the next complaint, and that is delayed development. Right? There is one more complaint here. Irritability. This child has been irritable, always irritable since long. They don't know when. How do you interpret this complaint of irritability? He's a 4.5-year-old child, chronically irritable. How do you take this complaint? So why does the child become irritable? Chronic irritability.
It could be present in SAM, sir.
Okay, very good. So it's rather a brain irritation due to some deficiencies or deficits or nutritional. But by and large, many times SAM becomes lethargic, right? Not irritable. So generally, irritability to us is some kind of
iron deficiency leads to irritability, sir.
Very good, very good. But then isolated only irritability or many other things will happen by that time. Fine. We'll take this. See, ultimately, when we take a case clinically, we take one symptom, we make some reasons for that. Then we add a new symptom, find the reason for that, and see the common symptom of the two, and take forward the third symptom added, find the common symptom. That's how we start shortlisting the differential diagnosis to come to the diagnosis. So let's take it. Now, irritability to me is generally a pain or hypoxia or some psychological causes, right? So rather most important is pain. That's what many times we get, a pain, right? So let's go with that. Hypoxia. Can this be child having hypoxia? Can this be child having hypoxia and irritability?
Severe anemia may lead to sir, sometimes irritability because of CNS hypoxia, sir.
CNS hypoxia. So anemia gives rise to irritability due to hypoxia.
Yes, sir.
Why nutritional anemia gives rise to irritability? What is the first manifestation of iron deficiency anemia?
Irritability and behavioral changes.
That is due to iron is an excellent metabolite for the or a neurological system, for that matter all the system, but predominantly neurological, and that's a cause. It's not because of hypoxia. For one to become hypoxic due to iron deficiency, it takes too late. It takes too late, right? So irritability can be because of iron, but that's a subtle irritability. This is obvious when some mother says that my child is always irritable, cranky. Look for any pain, something which is missed. Fine. Let's move to the third complaint, delayed development. Now this child had started sitting at 1 year, started standing at 2 years, walking at 2.5 years, then stopped standing also. And since last 1 year, so for 1 year he was not walking, and then since last 1 year he's just sitting, he can't stand also. This is motor. Fine motor, not much of a problem. Cognitive looks reasonably okay. Now, how do you interpret this growth? Is kind of a development. Somebody, Dr. Mridula Jain, you are not talking. Please tell us. How will you interpret this development pattern? Dr. Mridula, you are there? Fine. Dr. Vidisha, how do you look at this? Dr. Vidisha, how do you look at this development?
So regression.
Regression. Excellent. So as the pattern goes, it looks regression. Now, if it is regression, what will you expect in the various domains? There are, which are the domains of development?
So there are gross, motor, social, language. So in the history, so it's one.
Yeah, I told you he started sitting at 1 year, standing at 1.5 years, walking at 2.5 years, then stopped walking. At age of 3.5 years, even he could not stand. Now he only can sit. So what more?
So there is a gross.
Yes.
So there is a gross regression, so that we can see that the child is able to sit.
So where is the anatomy of this regression? Is it gray matter, white matter? Is it upper motor neuron, lower motor neuron? From the history, can you tell us? I give you the other milestones as well.
Yes, sir. The child was feeding himself and.
Right.
So there can also be vitamin D deficiency because the regression is just there in gross motor development and not in other parts. Other parts, although there is developmental delay present, but the regression which is present is there in gross motor.
Excellent analysis, but I will maybe taking slight caveats to that. What you said is perfect, right observation. It's only motor delay, that too predominantly gross motor delay. Fine motor and cognitive and speech is not delayed. Almost normal, right? But you must have seen so many vitamin D deficiency, right? How many times you saw some child losing the milestone so rapidly due to vitamin D deficiency? Have you seen something like that?
No, sir, not so rapidly.
Absolutely. He has regressed, right? The child may. And secondly, vitamin D deficiency, this child's whole history is of 4 years and he was growing well for first 1-2 years. Now, which children you see vitamin D deficiency? Classical vitamin D deficiency is a disease of growing bones.
Infancy, growing bones.
Growing bones, right? Now, what is such a disease in this child where vitamin D is stopping him from growing at all, rather losing the milestones, right? So nutritional anemia may delay the milestone, but somebody regressing the milestone just by nutritional deficiency, one has to be extremely severe and isolated. Vitamin D deficiency per se causing loss of milestone is extremely rare, or rather I have not heard of. Okay, so rightly said. So what else can cause regression of only motor milestones without any fine motor, cognitive, speech? So first of all, tell me, where is the problem? Is it gray matter, white matter, upper motor neuron, lower motor neuron, spine? Where? If I have to say only gross motor milestones are lost. Is there any such pathology which will have only gross motor affection with rest everything being nearly normal? And this is an acquired affection, mind you. And Dr. Vidisha, unmute yourself. Dr. Vidisha, unmute yourself. Yeah.
So since only gross is involved, so I feel it's more of an element kind of involvement where we can think of myositis maybe.
Okay, myositis, and I said the upper part of the body.
Localized, sir.
I said the upper part of the body he is moving quite well. Only the lower part.
Yes, sir. He's feeding also himself. That's what you mentioned in the history. So only the lower part is involved.
So myositis going on for 1 year. Itis is an inflammation.
You said. Yes, sir.
No. 1
15
year.
days
His
1 year,
cough.
okay.
15 days is Anasaka.
Okay, Anasaka. Sorry, sir.
Yeah. So,
sir, could it be vitamin C deficiency, which leads to painful joints?
absolute wonderful. So this is not fitting in any specific neurological pattern. And then I told you he's been chronically irritable. So he's having some pain. So is he not moving the limb because of the pain? And then that brings you possibility of some additional nutritional deficiency, whether it is vitamin C. Excellent, excellent, Dr. Ifa Khan. Thank you very much. So now, moving to last complaint which I said, first is edema, second is irritability, then third development, and the fourth one is a skin complaint. So this child started developing the skin complaint at age of 3 months, and it's progressive and going on till now, which is what a likely complaint which will come, and then say reddish skin, scaly, pruritic. What is the likely possibility? What kind of a complaint, Dr. Gunjan? What are the condition you've seen like that?
What it's coming in my mind, like it's all is related to severe malnutrition, because it also presents with the scaly pain, dermatosis, and matlab, sir, I feel like there is some nutritional deficiency which is leading to skin manifestation.
So when did this skin problem, Dr. Shubhika, you're quite for some time. Now, when did this whole problem started? The skin problem started at what age? I said.
You said a skin rash started at around
3 months of age. 3 months of age. So which is that nutritional deficiency coming at 3 months of age, giving rise to the rashes to be persistent till now?
Vitamin B12.
So vitamin B12, does it give rise to skin rashes at 3 months? What are the presentation of B12, vitamin B12 deficiency?
Zinc maybe there, sir.
What are the presentation? Sorry?
Sir, zinc deficiency.
Zinc deficiency, unless it's a genetic onset, won't come so early. Vitamin B12 at 3 months will be megaloblastic anemia and a neurological presentation. Okay, so by and large, none of your neurological, none of these presentation would start at 3 months and would continue like this. Okay, again, I describe it's a reddish, scaly, pruritic rash. It's a reddish, scaly, pruritic rash. What is the description? It's more of an allergic. It could be atopic dermatitis, allergic dermatitis. Somebody are diagnosed as outside as maybe psoriasis. We are not experts at it, but looks more like an allergic condition. Now, can someone summarize these four complaints together? And what are the 4 conclusions which you made out of it? Sorry. Dr. Rifa, can you unmute yourself? Dr. Mridula Jain, those who are on the dais, students, please keep unmuted. So can somebody summarize and try to make some differential diagnosis out of the history? Sorry.
Sir, gross developmental delay with hypoproteinemia.
But it's a gross motor delay and a regression of gross motor, right? Gross motor delay with only regression of gross. Generalized delay you may call, but regression is only gross motor. Then he has got hypoproteinemia. Then he has got irritability, which Dr. Rifa said could be vitamin C. And then there is last, which is some kind of a dermatitis, skin lesion. Perfect. So let's move back to the case again. So on examination now, his vitals, heart rate 110, BP is 100 systolic, his respiratory rate is about 24, temperature normal, saturation 98% at room air. And then this is his anthropometry. Note down these numbers. His weight is 12 kg, height is 93 centimeter, head is 47.5, is 4.5 years old child. The generalized Anasaka, pitting edema present on face, limbs, and abdominal wall. Rash is dry, ichthyotic, stretched, cracked skin, skin peeling on abdomen, chest wall, and limbs. This was a kind of a rash. Can you see the slide well? Right? This is kind of a rough erythematous rash on the body, and it is there all along. And note certain things which are there in the photographs. I want you to see the photograph carefully for half a minute and note the findings. This was the edema. Again, note the skin of the child. And this was a child as a whole. Few small cervical and axillary lymph nodes which are non-tender, they are sub-centimeter. Child was irritable, not allowing good examination. Few old pyoderma marks on the limbs. Hairs are sparse, golden black color, and no family members are having these kind of hairs. There are no joint swellings. Widening of the wrist, costochondral prominence. This is what I wanted you to note on that picture. There was definitely widening of the wrist. This was CNS examination. Higher functions are normal, cranial nerves are normal, motor, generalized hypotonia. Power, child is not so cooperative, but there are poor movements of the legs in the bed. So legs, he was not moving much in the bed as well. Upper limbs were 5/5. Lower limb was more than 3/5. Could not really elicit completely. But probably there are painful passive movements of all the limbs. Reflexes, upper limb normal, lower limb normal, no clonus, and planters were downgoing. Abdominal examination, there was edema, otherwise nothing significant. No organomegaly, very important. Respiratory system was normal, CVS normal. Now, what are the findings and how do you analyze this? Dr. Gunjan?
Yes, sir.
What are the, yes, please analyze the findings. You have noted the findings. First, tell me the anthropometry.
Sir, anthropometrically, he is underweight with stunting also there, and weight should be around 16 kgs at this age.
Very good.
It is around 12 kgs.
Perfect. Height?
And height should be around 102 centimeters, which is 93 centimeters.
Very good.
So stunting is also there.
So what is your interpretation from this anthropometry?
Sir, he is moderate underweight with moderate stunting.
One more parameter we take while doing this, that is weight for height, right? We have
Yes,
got a
sir.
weight
Yes,
for
yes.
the age, which is definitely
Yes, sir.
low. We have
Yes,
got
sir.
height for the age, which is not low.
Yes, sir.
Suppose
Yes.
some child, after these both being below third percentile, if weight for height is appropriate, now this child
Yes.
is 93 centimeter. At what age you expect this weight to be?
Sir, 12 kgs is around 1.5 साल का या सर 2 साल के बच्चे का ठीक है.
2.5 years in Indian circumstances, right?
Yes, sir.
And
Yes, sir.
93 centimeters, what is the age, appropriate age? Normally 93 centimeters. So that's yeah.
Sir, ये भी 2 से 3
Dr.
साल के
Vidisha, please unmute. Dr. Vidisha, please unmute. Yeah.
Yes, sir.
When you want to speak,
So-
please. Yeah.
So the weight is, sir, appropriate for an age of 2 years, and the height is appropriate for a 3-year-old child, whereas this child is 12 kgs.
Yes. If I say both the ages, weight as well as height is below third percentile, you call it, what is your interpretation? I'll give the differential: acute malnutrition, chronic malnutrition, or a constitutional pattern, or a genetic pattern. Which pattern is this?
chronic malnutrition, sir. Because stunting is also
Perfect.
stunting.
I just wanted to bring one point here. His weight is still low, but if you discount that edema, which may reduce the weight further by 1 kg maybe, and now suddenly you find this child is about 10.5, 11 kg, which is appropriate for just 1-year-old child, and height of 93 centimeters is appropriate for 3-year-old child. So his weight for height is grossly delayed. That's how it becomes chronic malnutrition. And what does it tell you in that case? When did the disease start?
It started earlier only, sir. Matlab, he is chronically malnourished, so it started in very early age.
Perfect. So it might have started in the first year itself.
Yes,
right?
sir.
So that is the importance of this anthropometry. So this is a chronic malnutrition. Probably the underlying disease has started at age of maybe around 1 year or so. Fine. Moving further, edema, which is Anasaka generalized. Lesions are like erythematous. He has got rickets findings. So can you interpret all these findings and give me your further case, Dr. Rifa? Can you interpret all those history and examination now together?
Sir, I think till now what I can make from the findings are it's acute and chronic malnutrition with
acute and chronic. We said just now
chronic. Sir, but weight for height is also very less, sir. Weight for height we have to see.
So again come down in acute. Okay, you are taking acute on chronic. Okay, I may accept it, but actually it's actually a chronic malnutrition. There is no reason of acute deterioration. While I'll take it. Go ahead.
Sir, with vitamin
okay,
C
go ahead,
deficiency.
Okay.
Sir, with hypoalbuminemia and with vitamin C, matlab, hypoproteinemia with vitamin C deficiency. This all I can make from.
And one more you missed.
Skin rash. It could be. I think it could be. It could be, sir, because of collagen issue. Because of vitamin C deficiency.
Not really.
But
You have seen vitamin C deficiency patients. What was their presentation? You must have seen occasional scurvy patient.
Skin and mucosal bleeds.
Mucosal bleeds. Anything else? Classical description. Pseudopulsy, pseudoparesis because of severe limb pain. They have got subperiosteal hemorrhages, severe limb pain, right? They have got pseudopulsy. Okay, and this child's irritability. And I gave you one more clue in the bed. He finds difficulty in painful passive movements. Right, that is the feature. So you got vitamin C, you got protein, you got dermatosis, and you have got vitamin D as well. I told you widening of the wrist and costochondral junction. Now rickets, if you say rickets, vitamin C is the disease of a sick child. Vitamin D is a disease of the healthy child. While this child is developing vitamin D deficiency. You got my question?
Sir, he is not able to absorb.
You are telling me all are nutritional deficiencies and vitamin D, vitamin C, protein. I expect vitamin D deficiency to be in the case of growing bone. This child is stopped growing long back.
Sir, because of lipid metabolism, sir, because the patient is in SAM, it could be there
but lipid metabolism का क्या finding मिला आपको? There are no diarrhea, no bulky stool, no foul selling stool.
No, sir, because of SAM, because patient is in malnutrition.
Excellent. Dr. Rifa, you must have seen so many severe SAM, right? When did you see rickets in a SAM patient? So if I get rickets in a malnourished child, I think of a secondary rickets, right? It could be renal osteodystrophy, it could be RTA, it could be rare hepatic disease giving rise to this. Why this child is developing it? So there's some entity called as atrophic rickets. So when he was initially healthy in the first year, he developed the deficiency which never got corrected. So bone maintained to be that, never had a recovery phase from that. That's one possibility, or it could be any ongoing. So even that malnourished child still requires some amount of vitamin D, which he never got it. And that's how. But at present, you've got vitamin C, vitamin D, we have got iron, proteins, and whatnot. Okay, and a chronic malnutrition. So now you tell me what is your interpretation? Gunjan, what do you think? What is the interpretation now?
Sir, severe.
Yes.
Sir, chronic malnutrition cause multiple nutritional deficiencies.
Fine.
To malabsorption syndrome.
Okay, excellent. I suppose you are coming to very close diagnosis just on the history and clinical examination. That's the beauty of approaching the case clinically. Let's move further with the case. Let's move further. We have got maybe another 10-20 minutes. Let's try and see whether we can crack this case. So differential diagnosis you gave, I'll give you the investigation now. This is his CBC 10.9 hemoglobin, MCV 86, RDW 19. He has got eosinophilic count of 13 out of his normal. So 13% makes almost about 1000 and maybe 1200, right? So note that ESR is 40, urine albumin creatinine is 0.4. What does it mean? So when you get a hypoproteinemia, edema, you want to know where that your protein is going. So whether it's a kidney. So here definitely kidney is not losing. Now this is a number which you definitely want. This SGOTPT is normal, bilirubin is normal, but look at the protein, 4.3 total, albumin 1.6, globulin 2.6. So severe hypoalbuminemia, that's the reason you want to know where is that protein going. So if it is not going in the kidneys, where is it going? You can lose protein only through main sources, GI or kidney. So here the protein is not going in the kidney, so probably is losing from the GI. Okay. Again, one may say it's a nutritional deficiency, but then going on for such a long time, and I say it's upper middle class. Why should have a nutritional deficiency, right? That is how you come to probably is losing on the GI. Now PT-INR is all right. This is his kidney function test, which apparently is okay, but look at his calcium, phosphorus, and alkaline phosphatase. What does it tell you? Severe hypocalcemia is total calcium. Phosphate is 3.48, alkaline 640. How do you interpret this number? Dr. Sheikh or Dr. Khan? What is this number? What does it? It tells you many things. You have got a clinical rickets, right? Does this number go with the clinical rickets?
Yes, sir.
What kind of calcium, phosphorus you expect in clinical rickets? If it's a nutritional deficiency, what drops first? What drops later? A plain simple nutritional ricket. If you see the child immediately within first month, see the child after 3 months and after 1 year. What will be the calcium, phosphorus in first month, in third month and later? So first to drop is phosphate. Once it is adequately lost in the kidney, what happens basically when there is a vitamin D deficiency? The absorption of calcium from the GI and retention from the urine will come down. So parathyroid, the plasma level will go down. Parathyroid secretion will be sort of compensative or protective, which will try to maintain the plasma calcium level by resorbing the bones and trying to retain the calcium from the kidney. And in exchange of calcium, you will lose phosphate. So the first one to happen is loss of phosphate. Phosphate will start dropping late first. When the phosphate is lost adequately, it can no more compensate for calcium. Then you start losing calcium. So what will typically get in early vitamin D deficiency? Borderline low phosphate, maybe near normal or low normal calcium, alkaline phosphate high. But when it is a chronic scenario, your parathyroid can no more maintain that, then the phosphate and the calcium also will go down. Alkaline phosphatase will be high. So this tells you this loss is happening for a long time. And this is probably, as we said, clinical rickets with this. So obviously, next thing you have to rule out whether it is renal pathology, but we don't have, see the electrolytes. Electrolytes are normal. Can this be RT? Sorry, it's a 4.2 potassium. It's not 42. 4.2 potassium. So one more thing you have to rule out whether it's a RT, renal tubular acidosis. So what does this electrolyte tell you? Can this be renal tubular acidosis? What do you get in electrolytes? Usually it's a proximal or distal tubular loss, and you got pan hypoelectrolytemia. These numbers are reasonably looking all right considering the chronicity. So probably we have got a vitamin D deficiency which is chronically happening. What more you want at this point of time? What else you want? Anybody? So we did the vitamin D deficiency levels which are less than 8 nanograms. So it's a severe deficiency. That can explain your calcium, phosphorus, that can explain your, so this is a nutritional vitamin D deficiency. Now we have got clinical probably scurvy, clinical hypoalbuminemia, nutritional deficiency, clinical vitamin D. Parathyroids are normal. We did this ACTH, cortisol, everything was normal. Suspecting the lower limbs were not moving well, we did the MG and CV, which was also normal. And this was an X-ray. So can someone, some PG, talk about this X-ray? What does it tell you? Someone quickly take it. Someone quickly take it. What does this X-ray tell you? Anyone, quick. We don't have much time now. Okay. Anybody? So look at this epiphysis, which is typical signet ring appearance.
Thin cortex.
Yes, please tell me. There is a signet ring appearance. Okay. You are having, then there are few occasional subperiosteal hemorrhages seen. The spicules formed. This is very typical. There is a porosis because of vitamin D deficiency also, but this picture is typical of scurvy. So here is osteoporosis. There is signet ring appearance. So this is vitamin C as well as vitamin D deficiency confirmed. The skin specialist, very senior person from Mumbai, Dr. Deepak Parikh, is one of the renowned in the all over the country. So he commented it's a atopic dermatitis, chronic, severe, widespread atopic dermatitis on the skin. Any more tests you need? I'll go through the case now. Now, so far, what all things you have got? He has got Anasaka. He has got irritability due to Anasaka, probably because of hypoproteinemia. Irritability due to vitamin C. Eczema, atopic dermatitis. Severe rickets, atopic rickets. It's a nutritional deficiency. Scurvy. Pseudoparalysis due to scurvy. Hypoproteinemia, we already said. And chronic severe PM, stunting and wasting. Now putting all this together, anybody wants to make any comment here? I think you already said it's a multiple nutritional deficiency of a very long duration in a otherwise middle class, good class family where there is no need for becoming somebody to be starving. So what is your conclusion at this point of time? What are the likely possibilities? Is everybody muted? Gunjan, Dr. Ifa Khan, Vidisha Singh, please comment at this point of time. Where is the pathology?
Sir, could it
Nutrition. Sir,
Malabsorption is happening. It could be protein energy, protein losing enteropathy.
Perfect. You are almost onto that. Now we'll go ahead and find out the further evaluations which were made in this child. So we have started on treatment. We admitted him because of the severe hypocalcemia. We gave calcium and we gave vitamin D subsequently. And he was increased the diet gradually. Proteins were increased. And after 3 days, he was discharged. This child was followed up. After 10 days, he almost completely lost the edema. We didn't give any diuresis. He lost the edema. Look at the weight from 12 has dropped to 10.4. Dermatocolic regions also reduced a bit. Irritability decreased markedly. He was given vitamin C, vitamin D, everything. And child has started walking with support. This is a child for last 1 year had not stood also. He was sitting, has started walking with support this minimal. This was a limb which you can see. The previous one was edema and this is one which is almost lost edema. But is it over? The father is asking, sir, when he will grow? So after 15 days, now he's got a first step, child has started walking, irritability is decreased, but I want to know when the child will grow. So what is your answer now? बढ़ेगा कभी तो ऐसे ही चालू रखो. Is that? Have we got the answer? Have we got the pathology? We have given the supplementation of all kind that we got it. We gave protein, we gave vitamin C, vitamin D, calcium, and he's shown the response. But is that all? Are we completely onto it? So child is improving. We don't have a diagnosis yet. Lots of unanswered question in a good class patient. Vitamin C, vitamin D deficiency, hypoproteinemia, Anasaka. And 15 days later, we repeated his calcium. Initially was 4.1, has come to 6.3, still quite low. Proteins is still lingering at that. It was initially 1.6 albumin, now it's 1.75, not improved much. So do you need any more test? What test you will recommend?
Sir, TTG and IgA, total IgA levels for celiac.
It's a good thought process, Dr. Gunjan. It's a good thought process, agreed. But as we said, the disease has started too early. But yes, I will still take it. Yes, it is possible. TTG, IgA, celiac disease has to be ruled out. I'm sure Dr. Shishir Bhatnagar will be giving us some more insights into this problem. So I'll try and finish up first so that he takes over subsequently. And yes, TTG, IgA. Anything else? So for TTG, IgA, for celiac, is that enough?
No,
What is
sir.
the definite-
Endoscopy.
So
The stool examination.
sorry, what you said?
Biopsy.
Yes. So let's come to that now, whether we got some further. We did the scope in this child, and this was eosinophilic enteritis. Eosinophil count is high. He has got chronic atopic dermatitis. He is 3rd-degree consanguinity. So he is genetically predisposed to these things. We are awaiting his genetic reports, but this was eosinophilic enteritis. So atopic dermatitis is allergic enteropathy. I don't want you to diagnose all these names. I think you have come reasonably to the conclusion of malabsorption syndrome. And as a postgraduate, that's far more than sufficient. If you can come to the conclusion that he has been losing multiple nutrients for a very prolonged period in a good class family where nutritional deficiency is not there, where the diet history is very important, and on that background he is not having, so plain simple protein energy malnutrition won't come with these features. And again, there to correlate the skin condition with a malabsorption, you may be coming to some kind of immunological allergic phenomenon. Now let's hand it over to Dr. Shishir Bhatnagar for this his expert comment on the eosinophilic enteritis or allergic enteritis. Dr. Bhatnagar, sir, please. Is he there? Is he there? No. Has he left? Dr. Shalabh, sir?
Sir, I don't think, sir, Dr. Shirish is here.
Okay, Dr. Kalra, sir, is there. Great. Dr. Kalra, sir's comment, sir, please. Sir, please unmute yourself. Please unmute. Sir, please unmute yourself.
It's been excellent, the way the teasing gradually coming round to the proper diagnosis. But yes, if Shalabh had been there, he would have been able to comment more on celiac disease and this losing enteropathy. So initially, when the skin was shown, the skin lesion, the dermatitis was shown, it seemed very clear that these were not Kwashiorkor lesions. There was, the Kwashiorkor lesions are very different. And I don't know whether this young generation, this generation has ever been able to see the Kwashiorkor lesions. Right. But this was typically, of course, this was not typical of a Kwashiorkor lesion. So I was wondering what it could be. And you are right, chronic atopic dermatitis because of association with celiac. Good.
Right. So over to Dr. Shalabh, sir. And excellent. All the girls did well. It's a girl predominant team. They did a wonderful job. They almost came to a diagnosis, or rather they diagnosed. Why should I say almost? Because that eosinophilic enteritis could not be diagnosed by any clinician. Even a gastroenterologist has to do a biopsy to come to that conclusion. They made a diagnosis of malabsorption. I think that's far more than sufficient from a postgraduate student. Congratulations. Thank you very much for a wonderful interaction.
Dr. Anurag, are you there? Dr. Anurag, for your comments. Dr. Anurag.
Yes, sir. Yes, sir. Thank you, sir. It was an excellent presentation, sir, and really an interactive session, and a diagnosis was released on clinical basis only. And any more questions? I think Dr. Alka is saying something. Hello.
So, any postgraduate wants to ask any question? Just please unmute and ask it away.
I think it was an excellent case presentation. We could, I was.
Any postgraduate has any question?
Hello, good afternoon. Sorry,
Dr. Shirish, yours awaited.
Dr. Shirish Bhatnagar, your comments. We had a case of eosinophilic enteritis,
Yes,
malabsorption syndrome. So your comments and your insights, your inputs to the case.
Okay, sir. Considering eosinophilic enteritis, basically it's a rare entity. Yes. The only thing is that what we need to differentiate is from the celiac disease, because the hallmark of celiac is also eosinophilic infiltration by Marsh grading. However, the differentiating point is that eosinophils should, in an enteritis, they are also present in the esophagus, where in esophagus there are no eosinophils. But if you have pan involvement in the esophagus also and the GI system, then we say that it is probably eosinophilic enteritis, but we have to always differentiate from celiac disease.
Okay. So you'll have to do a biopsy of the esophagus also, you mean to say?
Yes, definitely, because otherwise we will not be able to say just totally on that basis. We should always do, when we are suspecting enteritis, means there is involvement of the entire system, and we need to differentiate it from celiac disease also.
Okay.
So biopsy of this of esophagus is very much of prime importance.
Excellent.
Yeah.
So
thank you.
Thank you, Dr. Shirish.
And the large bowel involvement has also to be seen, because a lot of cow milk protein allergy patients also have proctitis, which has eosinophilic infiltration. So that has to be also seen in these patients. So pan involvement of the GI system is of much more importance, which has to be documented when we are labeling as eosinophilic enteritis.
Okay.
So we do both upper GI as well as lower GI endoscopy in these set of patients when we suspect eosinophilic enteritis.
This shall be did both upper as well as lower.
Yes. Yes.
And then with that they have labeled it as right.
Yes. Yes. Great.
So,
thank you. Thank you.
Thank you, Dr. Shirish, and thank you, Dr. Mahesh sir. Thank you, Dr. Kalra sir, Dr. Anurag Katiyar. I think this was a very exhilarating session. I think the postgraduate must have enjoyed it really. I think there is to study at postgraduate level is limitless, endless. There are so many books and so many resources at our commands. But there is one thing which cannot be taught by the books, and that is the clinical teaching and approach to the case, a problem-oriented approach to a case. I think this is what the objective we are looking at this PG session. And we are fortunate to have dissect this case in this clinical fashion. Clean PG teacher like Dr. Mahesh Mohite, and last time we had Dr. Baldev Prajapati sir. I think we will be looking to such more sessions every week after week in case presentation, and how to build up a problem-oriented approach to the diagnosis. So that will all we'll be looking forward in the next sessions. Thank you, Dr. Mahesh sir, and finally over to Dr. Alka Agrawal ma'am for closing remarks.
Thank you, sir.
Thank you very much. I think it was a very each step we were calculating, and we were trying to analyze what the steps were, and I went back to my PG days, how we used to analyze cases. And I just wanted to add that actually my own thesis topic was on celiac disease. So I just word which I want to say about that is sometimes TTG IgA will be negative, and then the diagnostic test still remains, or the golden test still remains is the biopsy. Right. So I think we should not write off celiac disease even if the TTG IgA is negative. And like Dr. Shirish said, that jejunal biopsy also is very, very important, and in fact the biopsy should be at multiple places, for esophagus as well as jejunum, where actually most of the absorptions take place. So it was overall a very, very, I would say, entertaining at this age, but I'm sure they learned a lot, and this is the motive behind these postgraduate teachings. And we hope to bring you more and more such cases every week. Thank you very much. And hope to see you next Friday. Thank you very much, Dr. Mahesh.
Thank you, madam.
Thank you very much, all the postgraduates. Thank you, both the chairpersons and all the esteemed faculty. I could see that Dr. Ashok has joined, Dr. Sethi had joined, and Dr. P.L. Prasad had joined. I'm missing a lot of names, I'm sure, but many people today had joined. So thanks to all of them, and we wish to make each session a more productive one and more informative for the postgraduate students. Thank you very much.
Thank you. Thank you very much.